equal benefit.
Great, thank you. We had a number of questions on circulating tumor DNA. So actually, there's 3 of them. I'm going to go through them. So one is, was there new data shared about the clinical utility of using ctDNA to detect a recurrence before imaging can? The second is, can you explain Signatera? And do you think it is an effective test in predicting breast cancer? And somebody in the UK, thoughts on NHS in UK study on ctDNA recurrence?
Yeah, no, so I think really important questions, because in essence, these questions are asking, what is ctDNA doing and should it be used? And, you know, my idea here is that the whole idea with ctDNA is it's trying to detect the fact that there may be some cancer cells left behind, right? So we all, when someone has a breast cancer, we do breast surgery, we worry, could there be a few stray cells that escaped into the bloodstream? We try to kill those cells with things like chemotherapy and sometimes hormone therapies. And then the question is, when you're all done with that stuff, are there still some cells left behind? And if so, how do we know? And can we know that so that maybe we could give another treatment to clear them before they have a chance to multiply and land somewhere else in the body and cause a recurrence from the cancer? And that's the whole idea between using ctDNA in this setting, is it's saying, is the cancer cells, if they're left behind, you know, they can emit DNA into the bloodstream, and can we find that DNA and know that those guys are there? And that's what these tests are doing. Signatera is one of those tests where it actually is a clever test, because it takes your tumor tissue, sequences that tissue, and then looks for those particular gene alterations in the bloodstream on a ctDNA assay. So it's personalized to your specific tumor and seeing if it can detect that ctDNA. And so that is one assay that is out there. I think the challenge that I have is these tests exist, but they're not perfect. So someone, for example, could have ctDNA in their blood, but the test could give you a false, you know, negative and say you don't have it. Or it could go the other way and it could give you a false positive and say you do have it when you don't. And there's some challenges, you know, with things chip and other things that can lead to that. And then even if it's accurate, let's say the test was perfect, then the question is, well, what do you do about it? Because if you tell a patient, hey, go get this assay, and the assay says, oh, I have ctDNA, well, then we're all worried, because it means that there is some cancer left behind, and it means you probably have a higher risk of recurrence. But what do you do at that point in time? And that's where we're stuck, where we're developing trials to specifically address this question. You know, can we give a new drug, for example, in this setting and clear that ctDNA and get rid of it so that there are no cancer cells left behind and we cure that patient? So does it give us an opportunity to intervene? So I think the answer is we don't know. Our group did a study that we had presented at ASCO last year, where we took women who had gotten at least 5 years of their hormone therapy and said, okay, well, let's look and see who has ctDNA detectable. About 10% of patients at that time point had detectable ctDNA. And when we follow these people, the majority of these people did have a recurrence of their cancer, sort of suggesting that picking it up does mean that you're predicting which people are going to recur. But the problem was, one, it's a small fraction of people where that exists, so you have to find those people. But two, what do we do to prevent that recurrence? And again, that's where we need to be able to develop intervention trials to give novel treatments to try and prevent that. So I'll say I'm not routinely getting ctDNA in my patients right now because the assays aren't perfect. And I don't know how to interpret them. Some of them false positives, false negatives, and then I don't know what to do with it. What treatment do I give them if they have detectable ctDNA? We don't have any data about how to handle that. And so we need more information here, but I do think it will be the wave of the future. So I think it is coming hopefully soon.
But if you have, just curious, if you have a detectable ctDNA, wouldn't you screen more often? Wouldn't it change the screening? I understand that, there's no treatment, but would it change the frequency of screening just so that, like if it progresses, it becomes visible elsewhere, it's treated as fast as possible?
So that's an excellent question. I do think anyone who has detectable ctDNA should get staging scans. unfortunately, in the triple negative setting with one of the assays that was utilized, and this was in the CTRAC trial, they actually found 70% of people had metastatic disease at the time of detection. So in fact, in essence, it meant it was too late, right? That there was no time to intervene and prevent that recurrence. And so I think the question is are we impacting someone's long-term outcomes by even doing this at all, right? And so that's why they think there's just too many unknown questions. I think that was done with an older assay. I think we're going to be much better with our newer assays, which are much more sensitive. So I'm hoping it will detect ctDNA prior to actually having metastatic disease. But I think these are all the unknown questions. It's an excellent question. I think we just don't know the answer.
Yeah. And also, we just got it on the chat. How about parent test ctDNA and ctDNA for finding out cancer cells left behind? So whether the treatment, whether I assume that
circulating tumor cells maybe is what they mean.
Yeah, like maybe that's what they meant. Yeah.
In addition to ctDNA. And it's interesting, actually, this was discussed at San Antonio a bit because there was a study presented using CTCs. And the question is, what's the role of CTCs compared to ctDNA? We've sort of moved gears and shifted towards more ctDNA use because it can also give you genomic information, whereas the CTCs just tell you if there's cells there. What we know with CTCs so far is it has been prognostic. So if someone has metastatic disease, for example, and they have high level CTCs, we do know it does suggest that they probably have a shorter survival than someone who has low CTCs. But I think, again, what do you do with that information is the problem. And I think, maybe you could think about combining information from CTCs with ctDNA to combine prognostic information with potentially, hopefully in the future, what we think is predictive information based off the genomics. But again, this is what we need to learn. We don't know, and we're not routinely doing this kind of stuff in clinic.